Afternoon, everyone. So I've been asked today to present to you a presentation in regards to some overhaul of blood administration training that happened when I first started in the Transfusion Practitioner post in October 2019. I used the sort of basis of this overhaul whilst I was actually doing the Florence Nightingale Leadership Programme. And as you'll see at the end, after I submitted the abstract, I actually won the Quality Improvement Project for the administration, the blood administration training that I adapted. So if we could go to the next slide. So I'm just going to go through a little bit of an outline because I think it's really important when we think about training at the core clinical level. So your nurses, your associate nurse practitioners, even your HCAs, these are the people that we need to get hold of and educate, depending on whether we are going to do sort of some of the basic observation training, whether we're actually going to do the blood administration training process or blood collection as well. So I think it's really important to see what SHOT says and their recommendations and the national recommendations of what we need to be upholding and why it's so important. I'll then touch on the actual training overhaul that we did, or I did, the outlining the problem, looking at some theory models to try and overcome the change and resistance that I came up against, and looking at the outcomes, and then a couple of acknowledgements at the end. Next slide. So as we can see here from the SHOT report that was published in 2019, we need to be aware that the majority of the errors that had occurred and reported to SHOT were sort of errors predominantly made via human error, things that weren't done in terms of correct processes, procedures, and there was sort of the statement that was made that inadequate staffing and the lack of adequate training, poor supervision and poor safety culture had been identified as the contributory factor to the majority or most of these incidents at SHOT. So touching on this quotes element, I took the lack of adequate training out of the requirements for what SHOT recommend to us as practitioners and our transfusion laboratory teams. So if we go to the next slide. And they recommend the following. So there's lots of recommendations in the SHOT recommendation outline, but for training and sort of updates and competencies. But these are the three that I identified and had a look at and thought, okay, these are the things that I'm going to hone in on, focus on, and have them as my core outcomes that I want to come to the end of my project. So we need to be making sure all our staff are deemed competent to take part in the transfusion process, whether it's blood collection, blood administration, the observations process, which our HCAs are part of. We need to be thinking about the identification of all blood components and instructions about appropriate dosing. So again, I know this was specific to the pediatrics, but again, it's honing in on our junior doctors, making sure that they actually have the adequate training in their university settings or even on the wards, that they do know how to dose appropriately and actually to pick up on key elements of TACO patients that might be more at risk. So yeah, making sure we cover that element. Ensuring staff are identified for training and that training material is thorough, and that staff competencies are assessed and updated frequently. So as we'll have a look when we come to BSUH, we weren't really meeting any of these recommendations that were actually being sort of set out to us. Next slide. Why do we have to be assessed? So this is the most common question that I get asked in all my face-to-face e-learning. Why do I have to do another reassessment? Why I did it a couple of years ago? I know what I'm doing is what the general feedback I got from when I sort of started challenging the processes that had been going on or had been going on. And I presented them to them, all these organisations that do stipulate that we have to have an element and a standard of reassessment of training for the administration of blood and blood products and also blood collection processes as well. Next slide. So this brings me on nicely to how this all came about at BSUH, and thinking about the key elements that hinders our sort of ability to be able to get people on board, getting people to train, getting people to be compliant. So next slide. And this is where we'll see where the problem was. We had in excess, when I started, of over 1,000 staff members expired in their mandatory training by that point of when I actually started my post. The numbers kept creeping up towards the end of 2019 as I was trying to facilitate further face-to-face, get some more dates on board, trying to restructure everything. And we had an issue where we didn't have the up-to-date internal training records. Even having a look now at sort of the blood collection training, we sort of had a cut-off from about 2017. So we don't actually have, and in terms of the blood administration, we're looking sort of just a couple of years ago that things sort of tailed off with keeping adequate record keeping. So we had a couple of these challenges where we were looking at, okay, right, people aren't doing the training, and even if they're doing the training, we haven't kept adequate records. So next slide. And the key observations that I made was in terms of the biggest thing was the resistance to change and to change unacceptable and outdated practices, attitudes in the clinical areas. And there were some key areas that kept popping up. So these are the sort of areas that sort of related to high usage of blood and blood products. There was a disconnect between the staff in the clinical areas and the transfusion laboratory. The clinicians didn't understand the processes in the lab, and the lab, I don't feel, had a full appreciation of the stresses and strains that were going on in the clinical area and how we were going to unite the two together to work cohesively. Unnecessary clinical incidents relating to near misses, whippets and wastage. So we started, or when I came into the post, we were having excessive numbers of whippets. We were having a lot of blood wastage because of people's inability to remember or to appreciate time expiries of blood products and blood components. We had a number of cancelled sessions prior to starting, and there was only one accessible means of actually doing the training, which was face-to-face. So again, there was a poor uptake and a poor compliance to actually turn up to some of these sessions. Training had been previously allocated to clinicians who were not actually even part of the transfusion team. So there had been people prior to me in the post who had allocated to other people, say within A&E, saying, yeah, you can do the transfusion training, that's fine, and that will be adequate. Whereas sort of when I came into the post, I took away all elements of sort of external training that we had no idea had been going on, and trying to revert that. We had poor compliance for, like I said, the mandatory assessments as per national guidance. Again, people were turning up to a face-to-face but not appreciating they actually had to be reassessed in clinical practice. Next slide. So how did I begin evoking positive change, and how is this actually done? So this is something that I've started to take on board as I've started doing my chartered management degree apprenticeship and looking at how we get people on side. How do we get people to change their perceptions and their values and their behaviours in a positive way without sort of causing an element of fear, and with the fear causing a lot of resistance? So next slide. And the first thing is we need to understand how change works, or had to understand how change works. But to do this, the conscious competence ladder is a great way of sort of understanding those changes. Realizing in the first instance, there is this unconscious incompetence, that there is this element of ignorance is bliss. No one really knows the problem's there until something actually happens, or someone actually comes in and says, I think there's something not quite right here, which then leads you on to a conscious incompetence. So actually saying, okay, I now am becoming aware of the shortfalls, and I'm now starting to verbalize this to people in power that may be able to facilitate change. The next stage, looking at conscious competence, is giving people the confidence, and essentially the acceptance will build, and the help that we give people will help get them up to the next step on the ladder. Unconscious competence is the final element at the top of the stairs where habit is installed. So we've gone from people sort of being blindsided, being the element of ignorance is bliss, to actually no, this is correct procedure. This is our habit now, that we are going to instill correct processes. Next slide. However, where there is change, there will always come an emotional connection. And as you can see, the stages of the unconscious competence, incompetence, conscious incompetence, conscious competence, and unconscious competence comes with elements of and lengths of time of emotional response. So when we start thinking about we're going to make change, you have to appreciate, and I had to appreciate, that people generally are unaware. They then have this fear and denial element that they've been doing something wrong for quite a long time. When people get fearful, they begin to resist the change. And it's about trying to get people to accept, trying to get people and support them to be more open to, through the testing elements, to relearn bad behavior. And then it becomes, like we said in the step, that it's habit, it's autopilot, that actually blood administration training is essential. It has to be done regardless of people's thoughts about the processes in terms of, oh, I've got to do the e-learning, I've got to do the assessment. Well, if you want to give blood, then this is what you actually have to do. Next slide. And then taking the elements of the competence and taking the elements of resistance and trying to overcome the elements that we're going to come up against. So the old-fashioned views, the denial, the fear. And to do that, we need to do and provide education. So if we click for me, Mol. So we need to provide adequate time to educate individuals as to why change is necessary. So we can't just go into a situation and say, yep, we're going to make the change. This is great. This is going to work. We have to give people some time to educate them and get them on board. We then need to get their participation, which is involving the appropriate individuals in change process and giving them a sense of inclusion. So if you include people in what you're trying to do and give them some options, then it tends to unite people together. And then that kind of resistance of, oh, it's just you nagging, it's just you making us do different things, to actually say, okay, right, well, we've got this choice. And from this choice, we would like to do this part of your change in blood administration. Facilitation then comes next. And with facilitation, it's remember change to some can be very fear-inducing and they resist it. And this is where the education and participation comes in, and focusing and facilitating the support for these individuals at those early stages. And again, facilitation is not just with the clinicians, it's with practice educators, it's with ward managers, it's with the matrons, it's with the clinical governance. We then need to find a good way of negotiating. So negotiating will involve collaboration with these decision makers. And as we start talking and as we start working through these things, fear and resistance will lessen as the inclusion element increases. So when we started with participation, it's sort of like, oh yeah, give me your thoughts. And now we're saying, right, this is what we're going to do. I want you to tell me if this will work. Will this be good for your team? Will this be good for A&E, or would it be better for theatres? The next part is manipulation, and manipulation is quite a sort of, it sort of hones in sort of negativity. So I've sort of termed it as cooperation and influence. And from my perspective is, well, if we're not going to do this, we're going to risk patient safety. And patient safety is first and foremost. Do you really want to harm a patient? So manipulation in a way of influencing someone's decision to say, right, okay, well, we need to make this change, but we need you to realise that this is at the top of our priority to ensure our patient safety. And if you're not going to do that, then be it on you. So it sounds really a harsh element, and manipulation then going into coercion is eventually sort of merging the two together. So with coercion, you're essentially winning people over from sort of that element of influence. So having a think of all these elements that I had to sort of encompass, it came down to essentially a lot of time on getting people on board. So if we go to the next slide. The approach I used is knowing the scope. So and for anybody else that goes into trying to make change, know what the problem is. Be very, very, very clear. The problem was we had excess 1,000 staff expired and people weren't keeping adequate training records. Research the problem. So you can't just go in guns blazing. You have to know where this has all come from. So learning and development team sent me years worth of spreadsheets of sort of historical elements of face-to-face training days that had been cancelled, and equating what the actual problem, that it wasn't just the staff, it was sort of transfusion that had to take a little bit of ownership for cancelled sessions and why these were happening. And that came on to asking really tough questions. Who is really responsible? Why has this happened? And what are we going to do to solve this? Have clear outlines for change, engage with others in position of change, formulate key objectives, knowing a timeline. So yes, I had to keep aside change time for the resistance, but we still had patients' safety at the end of this. So something had to be done quite promptly, quite quickly, to try and sort of facilitate the adaptation in training. Presenting the plan for change. So I presented this to the transfusion leads, I presented this to the clinical leads, getting them on board, getting their opinions, getting their feedback, and then eventually sharing the change. Next slide. So the outcome was this. So in terms of the e-learning going live, so to give you a bit of a background, it was always face-to-face training that then got postponed and was halted due to COVID back in March. And on the 21st of April, the e-learning went live, and the participant enrolment went up by 14.6%. So this was great for all those staff nurses that needed to have training for their redeployment and accessibility, and being mindful that the inductions to the trust had been suspended. So again, these kind of inclusions of people that were starting the trust needed access to the training. And then from January 2020 through to December 2020, we saw a 55.8% reduction in staff left to train by the end of 2020. Next slide. The e-learning participation, as you can see, shot up in May, and this coincides really with sort of what was going on during COVID last year. And it meant that the accessibility now wasn't just honing in on face-to-face. It was being able to actually go onto an online system, do an online assessment with the e-learning, some mandatory flashcards as well that they had to acknowledge. And we were able to get quite a large proportion of people trained during that period of time. And since then, we've had an average around 80 to 90 participants per month to the e-learning. Next slide. And to put it into a little bit of perspective, there is a 4-month advantage previously, because obviously as you can see from the left, it ran from January 2019 to October 2019, just as I started. And then my actual training went from November 2019 to December 2020, and over a 13-month period. But still, we had double the uptake using elements of face-to-face before it was actually suspended, induction before it was actually suspended. And I actually had the guest slot for the trust annual update, which I managed to get on and sort of do 2 to 3 sessions per week before it was suspended. And this also includes the e-learning. So it was drive, trying to get the expired numbers of people reduced on our list of blood administration training. So that sort of brings me to the end of presenting the facts and the figures here in the presentation. If we go to the last slide, I would just like to take the moment to thank Frontier Pathology for giving me the opportunity to take part in the days that was facilitated by the Florence Nightingale Foundation and BSUH for offering me the opportunity in the first place, and for the South East Coast Transfusion Committee today to actually sort of verbalise sort of my achievement, and also to show how well we have come. Even through a pandemic, you can do and invoke positive change, and you can overcome the resistance, and you can overcome the fear with some time, and with some sort of element of understanding of people and clinical areas. And for that, we will, at the end of it, ensure our patients' safety. And if we go to the last slide, I like this by Ben Franklin. Investing in people, investing in training, investing in time, elements. It pays the best interest at the end of the day, and the interest that we're looking at in this clinical area is our patients. So yeah, I love this sort of quote, and I like using it a lot in my training as well. And if you guys wanted to look at any of the theory elements that I've taken, they are in the slide here. Some of the images I've taken aren't taken directly from my chartered management degree apprenticeship, but they've come from sort of elements where they do better representation of diagrams and visual aids as well. So yeah, that's that. Thank you very much.